Okay, I think I got this right. Okay, good morning, everybody. As you know, I am Edwin Jackson. Welcome to all the applicants. We're thrilled to have you here today. So this is going to be our last talk of this chest conference, and I'm going to be making a case for POCUS transcranial color Doppler. So as I talk about this, I'm going to change transcranial color Doppler to just TCD because it just sounds weird to say all those letters. This is going to be an interactive discussion, so go ahead and scan the QR code so that you can answer some of the questions. I won't be keeping track, and I will not be sending you $5 if you get them all right. This is just for audience participation. All right, so here are our learning objectives. We're going to summarize the role of ancillary testing for brain death based on the new 2023 guidelines. We're going to explain the fundamentals of color and spectral Doppler as applied to intracranial hemodynamic assessment. You're going to be able to understand the proper Doppler interrogation of the middle cerebral artery. And then finally, you'll be able to interpret POCUS TCD waveforms in the setting of cerebral circulatory arrest. So we will start with a case. You're at Eskenazi. You're seeing a 39-year-old female who was found down at a local gas station. Unknown downtime, EMS arrives, they perform CPR and intubate her in the field. ROSC is achieved after about 25 minutes. Upon arrival to the emergency department, her chest x-ray shows diffuse bilateral infiltrates. She is in shock. She's on 2 vasopressors at this time. GCS is 3. Her UDS is positive for fentanyl. TTM is initiated. And prior to doing that, a head CT is obtained. So here are the slices from the head CT. So you see it's a little bit crowded in there. So we have loss of gray-white matter differentiation. And this is right after she arrived to the emergency department, so we're a bit concerned. 72 hours after the arrest, she's having worsening respiratory failure. She's on 70% FiO2, 8 of P per PaO2 is 65. Her GCS is still 3, and she's had no sedation. She's back to her normal temperature. She's still on norepi at 15 and vasopressin. You get an MRI of the brain, and it is consistent with a noxic brain injury. So jumping to these updated guidelines, and I'd like to thank Seconder for sending these out about 6 months ago. It's the first time I really had a chance to take a look at them. And it's a relatively interesting document. There's a lot of information in here, and there's a lot of opinion. I put a QR code down there at the right-hand corner of the screen on the bottom, so you can scan that and actually take a look at this document for yourself. But based on these guidelines, should we begin brain death testing in this patient? Well, we do have a patient who's in a coma. We have clinical and neuroimaging evidence of an acute CNS catastrophe that's compatible with brain death. This is recommendation number 7. We also have an adequate observation period after the event. This is recommendation 4 and 9. And then we have absence of confounding factors. So BP's okay, temperature's okay, there's no CNS depressions, we don't think there's an infection going on. Recommendations 10 and 12. So based on that, you begin your brain death testing, starting with your clinical and cranial nerve examination that is consistent with brain death. So what is your next step after that? And you can go ahead and shout that out for those of you in the room. Is it A, apnea test, B, an EEG, C, 4-vessel angiogram, or D, a brain MRI? A, apnea test, correct. Very nice. So you perform your apnea test, and within 3 minutes, her SpO2 drops to 82%. She's already on 100%, keep that in mind. And her systolic blood pressure drops to 80. What should be done next? So you can go ahead and shout this out. A, should we stop the apnea test? B, should you just push right through, continue it? Or C, stop the apnea test and consider ancillary testing? C, all right. We're doing well today. I guess you are. So looking at our guidelines, there are indications to abort the apnea test. And per these guidelines in recommendation statement 25, you'd want to stop with a systolic blood pressure of less than 100, or a progressive decrease in oxygen to below 85%, or a cardiac arrhythmia with hemodynamic instability. So we're right on target there. So you decide to move forward with your ancillary testing, but which one should you do? Go ahead and shout it out. Should we do an EEG, a CTA, an MRA, or a nuclear medicine perfusion study? What do you think? D, nuclear medicine perfusion study. All right, very nice. So looking at these guidelines, this is an update from 2010, and this was relatively surprising to me. But recommendation statement 28 says you should not use EEG, AEP, or SEPs, that's auditory and sensory evoked potentials, as ancillary testing for brain death. The rationale here was that that's not evaluating the brainstem, because you can have a pretty flat EEG and still have brainstem activity, so they took it out. Next was the CTA and MRA, which also surprised me. They basically said you should not use this for ancillary testing either. The rationale here is that there's lack of validation in national protocol. So a lot of people were getting these tests. We were thinking they were brain dead, and they actually weren't. So in the updated guidelines, they recommend against their use. So the only thing left, and you chose this correctly, was your nuclear medicine perfusion scan. So here are the representative images of that scan. So is your patient brain dead? Yes or no? Okay, very nice. They are not brain dead. Now, this isn't a talk about nuclear medicine perfusion scans, but I do think it's important to understand what the radiologist needs to see in order to declare someone brain dead. They need to see absence of intracranial radiotracer on the nuclear medicine perfusion scan with preserved extracranial activity. So if you look on the right-hand side of the screen, this was our patient. So we see the external carotids here, and we see tracer uptake in the brain. If you look to the left, we see external carotid uptake, but no radiotracer in the brain. This is called the empty skull sign. Okay, so our patient definitely has perfusion. So now we're in a situation here, 48 hours later, clinical status is unchanged. You repeat your clinical and cranial nerve examination, still looks like brain death. You're also unable to perform the apnea test. Now, one thing I didn't tell you about this patient is that they don't have any family available. We haven't been able to contact anybody, but we did find a license. And this person is a designated donor in the state of Indiana. So, Indiana Donor Network approaches you very nicely, and they say, would you mind repeating the nuclear medicine perfusion scan? You call down to radiology, they tell you, hey, the tracer is pretty expensive. Actually, it's $1,934 for a single dose, and you just used one 48 hours ago. Are you sure you want to do it again? So the question for you is, do you repeat the scan? Yes? No, we'll wait another 48 hours, see if the patient declares themselves. Or no, we're going to ultrasound their brain. So yes, I'm going to repeat it. What'd you say? I don't know. Depends on if I'm scanning. I can add on a few charges. I heard ICU bed was around $5,000 to $6,000, but I don't know how accurate that is. Just the bed. Yep. So it's expensive. The trace is cheaper than the night. But I will tell you, we get a fair amount of pushback when we try to order these scans. They always tell us how expensive the tracer is. So I actually reached out to Janice, who's the manager down there, and she quoted me this price. So even if you order the tracer, what's that? I couldn't hear what you said, but okay. So the correct answer is C. We're going to ultrasound the brain. Surprise, surprise. So here's the brain ultrasound. I know Dr. Williams knows this ultrasound well because we did this probably 50 times. So you ultrasound the brain, I just showed you the clip, and what you see is diastolic forward flow in the MCA. So based on this finding, should you repeat the nuclear medicine study? Yes or no? Then you get the same thing, okay. So you're right, correct answer is no. So what you found here, you did a POCUS TCD, and you saw forward diastolic flow. When you see forward diastolic flow in the brain, that is incompatible with brain death. If you see that, your patient is not brain dead. They do not have cerebral circulatory arrest. Right? So jumping back to our guidelines, and we look at the use of transcranial Doppler, it actually says detection of oscillating flow or systolic spikes in proximal large arteries is consistent with brain death or death by neurologic criteria. Recommendation statement 31 says clinicians can use transcranial Doppler in adult patients as an ancillary test for brain death. Now we have to make a distinction here between a formal transcranial Doppler and a POCUS transcranial Doppler. We're doing a POCUS test, okay? So here's the distinction. A formal transcranial Doppler, much like a formal echo, is done by a sonographer or a neurosonographer / neurologist. It's a comprehensive exam. So it's looking at the anterior and posterior circulation. It's looking at each vessel. It's looking at the velocity and pulsatility. There's a structured reporting system for this, and it is in the medical record. Now what we do a POCUS transcranial Doppler. So I do this, the fellows do this, and even the emergency department, they do a fair amount down there. And it's a rapid, question-driven exam. We look at 1 to 2 vessels, and it's almost always the middle cerebral artery, okay? Now it's limited, and you can't use this to say that your patient is brain dead, but you can use it to say that they're not, okay? The advantages of this is it's repeatable, it's non-invasive, it's immediate, and then you can look at clinical changes. So if something happens to your patient, you start to get worried, you put the transcranial Doppler on, you kind of see what's going on. Now, it's not without its drawbacks. It certainly is operator dependent. It's not the easiest exam to do. And approximately 10% of patients have inadequate transtemporal windows, so you actually can't see the MCA. And finally, you need a fairly decent ultrasound. You can't use one of those vascular probes to do this. So speaking of equipment, in all of our ICUs, we have a Sonocyte PX, and it comes loaded with the transcranial package. So you select your phased array transducer, you scroll down, and you select transcranial. It's already there for you. This flips your probe indicator to the left-hand side of the screen. It adjusts your color and pulse wave Doppler, and it gets you ready to go. So in terms of doing this exam, your patient is going to be supine, at least 30 to 45 degrees. You're going to take your cardiac probe or phased array probe. You're going to put it in the transtemporal window with the probe indicator facing towards the patient's eye. Okay, index marker is going to be on the left. You start scanning at about 14 to 18 centimeters. And then the MCA should be between 3 and 6 centimeters. So this figure comes from the American College of Emergency Medicine. And you can see we have our circle of Willis, and we have our left MCA going right towards that temporal bone and the transducer. Here's a coronal CT. So you can see kind of where you're scanning. You're in that midbrain third ventricle area. Again, transtemporal window with probe indicator going towards the patient's eye. Here's an example of how this is going to look to you once you put the probe on the patient's transtemporal window. So you're going to start out and you're going to see this hyperechoic structure. This is the contralateral temporal bone right there. You're going to decrease your depth and you're going to start looking for the cerebral peduncles, the thalami, and the third ventricle. If you look very closely here, you can see CSF going through the third ventricle. Once you see that, you're going to place a large color box over the middle portion of the brain, and then you're going to slowly fan through, and you're going to look for a red Doppler signal indicating blood flowing towards your transducer, and that's going to be your middle cerebral artery, which is right here. So the middle cerebral artery is what we're looking at. It's the easiest artery to Doppler in the brain. And we can also see other arteries, but remember, we want to focus on that MCA. you want to remember that in a normal brain, blood should be flowing towards your transducer in that transtemporal window. So the flow should give you a red color. Now, it's important to understand a little bit about color Doppler. And I know all the fellows are tired of seeing this slide. How many times have you guys seen this slide? You saw it yesterday. Okay. And you're going to see it tomorrow. So for color Doppler, this is a pulsed wave Doppler modality. And color Doppler is telling you about velocities. Remember, velocity is speed and direction. So in our current setup, we have blue going away from the transducer and red going towards. It's not like that every time, but it's like that most of the time. So if blood is flowing towards your transducer, it's going to be red. Remember, we're looking at direction and speed. So the faster that blood is flowing towards your transducer, the brighter the red. It can also become orange and sometimes even white. If blood is flowing away from your transducer, it's going to be blue. The faster it's going away from the transducer, the brighter the blue. Okay? So that middle cerebral artery in a normal brain should be red. This is also one of my favorite slides. You guys, I think you might have saw this yesterday too. This is an example of color Doppler. So you can think of color Doppler as a way to find the highest flow. As you're looking at this, this is a peristernal short axis view. Okay, this is of the heart, not the brain. We're at the level of the aortic valve. We have the right ventricular outflow tract here, tricuspid valve, right atrium. We have our transducer here. So as we watch, you're going to see blood flow that's blue going away from the transducer in systole. This is an example of tricuspid regurgitation. Now that we found that highest flow, we can transition to our spectral Doppler. Okay? Color Doppler finds the highest flow. Spectral Doppler is going to measure those velocities for us. So remember, we talked about blood flow going towards the transducer or away. Spectral Doppler is telling you basically the same thing, except it's doing it in slightly a different way. So you have this zero baseline here. If there's a deflection below the baseline, that indicates blood going away from the transducer. If there's a deflection above the baseline, that's blood flow going towards the transducer. That's our direction. If we look at the right-hand side here, we can see our speed. So I can tell you that there is a spectral tracing going away from the transducer at around 40 centimeters per second. That's our velocity. I can tell you here that there's a spectral tracing going towards our transducer at about 20, 25 centimeters per second, okay? We can also tell how long these tracings are lasting in milliseconds, so I can actually measure the amount of time it takes. So our spectral Doppler tracing tells us about velocity, speed, direction, and time. So let's take a look at our transcranial Doppler here of our patient. We have color Doppler, we have that red MCA, we have our sample volume from our pulse wave Doppler, and then here we get our spectral tracing. So based on what I just told you, what can you tell me about this tracing? Is it going towards the transducer or away? Towards the transducer, so it's forward flow, and that is appropriate. Let's take a closer look at this. Again, we have our transducer here in the transtemporal window. The question I have for you is, what part of the cardiac cycle is represented by the letter B? Is it systole or diastole? Say it again? That correct. This is diastole. If you remember nothing else from our conversation today, in a normal brain, blood flow is forward throughout the cardiac cycle, okay? The cerebral circulation is designed to maintain continuous forward perfusion. That means blood flow is going forward in both systole and diastole. So you should always see blood flow above the baseline in diastole. If you don't, that's telling you that there's elevated intracranial pressure and that blood flow is going the wrong way. Now let's think about the final common pathway for brain death. We have an acute rise in your intracranial pressure. We have essentially extrinsic compression of your CNS vasculature, preventing blood flow into the brain. Okay, so we have a Doppler signal that can give us an early warning sign of elevated ICP. So this relationship between elevated ICP and cerebral circulatory arrest has been well described. The first description was in the Journal of Neurosurgery back in 1989, when a group of neurosurgeons took 65 patients, they did 4-vessel angiography, and then they did transcranial Doppler as well. And they looked at these patients through the course of elevated ICP all the way to cerebral circulatory arrest. And they found 3 patterns that were consistent with cerebral circulatory arrest or brain death. The first was an oscillating or biphasic flow. So during the cardiac cycle, you had blood going forward and then blood going backwards in equal velocities. They also found what's called a systolic spike, so a short elevation in your velocity during systole with 0 diastolic flow. Then they also found, which seems quite obvious, complete loss of a Doppler signal. But remember, to say they had complete loss of a Doppler signal, you actually had to have a Doppler signal first. So they found it, and then as the pressures went up, the Doppler signal went away. Now here's a figure from that paper. As we look at this, we see systole and then that slow deceleration, and then another systole and a slow deceleration. As you have a decrease in your cerebral perfusion pressure, you start to get blunting of that diastolic flow. Finally, the diastolic flow disappears and you get diastolic flow reversal. In cerebral circulatory arrest, you have that oscillating flow, systolic spikes, and then finally no flow. And this occurred in 65 out of 65 patients. Now, just remember, cerebral perfusion pressure is MAP minus ICP. And really the only thing you have to think about here is as ICP increases, your cerebral perfusion pressure decreases. So let's take a look at an example of diastolic blunting. So you can look here, we have our 0 baseline, we have systole, and then we have a loss of our flow, and then just a little bit of flow here in diastole, so clearly abnormal. As you compare this diastolic blunting to our normal transcranial Doppler, you can see that this is easily identifiable. As ICP continues to increase, you have your systolic flow, and then you have diastolic flow reversal. So this is telling you that your ICP is either equal or greater to your diastolic blood pressure. So instead of that continuous forward flow, now you have forward flow and backwards flow. Now, neither of these are consistent with cerebral circulatory arrest, but they are telling you that there's increased intracranial pressure. So let's jump back to our guidelines and take a look at what they say. Detection of oscillating flow or systolic spikes in proximal large intracranial arteries is consistent with brain death. Okay, so let's take a look at what that looks like. Here's our oscillating flow. So we have a velocity, direction forward, speed, and then we have essentially the same velocity, but in the other direction, right? So this is telling us that we have a net 0 for forward flow, consistent with cerebral circulatory arrest. Now, if you look at this and you compare it to your normal flow, you can see that it's quite different. When we look at the next step, these are our systolic spikes. Now, this takes a bit of a discerning eye. I want to draw your attention to our centimeters per second, or the speed of this spike. You can see that it's relatively low. It's only 40. So it's a very short, small, and quick spike that you see here with no diastolic reversal. There's nothing going on in diastole. There's just a little spurt of blood that's being caught by your transcranial Doppler in systole. Now, the way that you tell if this is a true systolic spike, it's got to be less than 200 milliseconds in duration. So from here to here is less than 200 milliseconds, and it's got to be less than 50 centimeters per second at its peak velocity. Okay? If you see this on a formal transcranial Doppler, this is consistent with brain death per our guidelines. So here's how this looks. When you compare it to our normal, we can see that our pressure here, our velocity is about 150 centimeters per second. This is 40. We see that good diastolic forward flow, and we see none here, okay? So this is our short clip challenge, week 76. Let me go back. So now that we've talked about this a little bit, let's see if we can answer these questions. There was only like 75 people that did this one, so I feel like this was a little bit of a drop off. But looking at this, what vessel is that? MCA, exactly. The harder question to the right, this is our spectral tracing. What's going on here? What's happening in this person's brain? Is this a normal spectral waveform? Increased systolic velocities consistent with vasospasm? Or is there a reversal of diastolic flows and raised intracranial pressure? C, correct. So looking at this might be too small for you to see, but you know that this isn't a systolic spike because our peak velocity is 150 centimeters per second, and a systolic spike has to be less than 50. We do see some diastolic reversal, so we know that our intracranial pressure is at least higher than our diastolic blood pressure. So reversal of diastolic flows and increased intracranial pressure. So we've said all this, but how are you going to use this in practice? What should you do? So my recommendation for your POCUS TCD workflow is any patient that comes in with a GCS of less than 3, if they have a traumatic brain injury or they're post-cardiac arrest, I recommend you go up, you put the probe in the transcranial window, and you see what you get. It's important to do this as soon as they come in because in subsequent days, if there's loss of flow and you haven't done this before, you may think this could be the 10% of patients who just have a poor window. But if you're able to get the flow when you come in, you can document that and then repeat it like Dr. Williams and I did every day for probably 2 weeks. And you can see that there are changes, okay? This can prevent you from ordering inappropriate nuclear medicine tests, or you can even see that diastolic flow reversal and say, boy, the intracranial pressure is going up, get a head CT, kind of figure out what's going on. Now, this exam may seem a little bit daunting, but after doing several of these, you'll be able to get the MCA in under 2 minutes. It's not going to take you a large amount of time. So let's go back to our case. Here we have our middle cerebral artery. We clearly see that this individual has forward diastolic flow. So we can say with a lot of confidence to IDN, they are not brain dead by criteria. This patient's family was from out of state. They were from Kentucky. They ended up being able to come up to Indiana, to Eskenazi, and they did honor the patient's wishes to be a donor, and she was able to participate in a donor program. They took her heart, her kidneys, and I believe her cornea, excuse me. So this tragedy for that family was actually a blessing for several other families. So there ended up being a reasonably okay outcome. Here's my favorite paper from CHEST. This is from the Better with Ultrasound series. There's a gentleman up in Canada named Rob Arnfelt, who's really a thought leader on POCUS transcranial Doppler. I encourage you guys to take a look at this paper. It actually expands on the uses of POCUS transcranial Doppler to look for things like vasospasm, intracranial hemorrhage, and there's calculations to measure or estimate ICP. So one of the simplest things that we can do is just look for cerebral circulatory arrest. So that's how we use it, but it can be used in multiple different ways. Remember that this is not going to tell you if your patient is brain dead, right? Because you could have some blockage on the left MCA, maybe that basilar artery is still open, but it is going to tell you that they're not, okay? So just like with our POCUS cardiac exams, if we have a question, maybe we see endocarditis, we're going to order a formal echo to document it formally. Same thing here. This is going to help you spend more time at the bedside, get more information, and keep you more informed in the care of these critically ill patients. All right, it is 8:25. Here are my references, and I'm happy to take any questions. I can't say I do it often for those patients. My use cases are usually if someone comes in and they have a cardiac arrest, or if there's a lot of back and forth about, do we need to repeat brain death testing? I'll do it every day and document it in the chart, say diastolic flow, we don't need to do anything. So